Hello, everyone. Thank you very much for joining us. My name is Mosab Awadelkareem. I'm from the Society of Neuroscientists of Africa. Currently, I'm a postdoc at University of Oxford. I'm very pleased to welcome you all to SONA webinar series, which is organized by the Society of Neuroscientists of Africa, Trend in Africa and Worldwide Neuro Initiative. Today, we are very fortunate to have Professor Clifford Woolf to talk about selectively silencing nociceptor sensory neurons. I'm quite sure Professor Woolf doesn't need an introduction, but let me quickly introduce him. Professor Woolf was born and educated in South Africa, became a neurobiology professor at University College London, then the Richard J. Kitts Professor of Anesthesiology at Harvard Medical School. Currently, he is the director of FM Kirby Neurobiology Center at Boston Children's Hospital and professor of neurology and neurobiology at Harvard Medical School. Professor Woolf is a member of the American Academy of Arts and Sciences, and he has received numerous awards and honors, including the Gill Distinguished Scientist Award, the Reeve Irvin Medal, and Doctoris Honoris Causa from the University of Lausanne. His lab studies how different forms of neuronal plasticity contribute both to adaptive and maladaptive change in the mammalian nervous system in relation to pain, inflammation, and regeneration and neurodegeneration. So before we get started, just would like to remind our audience, this webinar is designed to be interactive, and you can ask as many questions as you want by simply typing your questions into the Q&A box at the bottom of the screen, and Professor Woolf will reply at the end. Please remember to type your questions into the Q&A box, not the chat box. Professor Woolf, thank you very much again for accepting our invitation and for taking time out of your busy schedule to join us today. And now I'm going to turn it over to you.
Great. Thanks very much, Mosab. It's a real pleasure to be here with you. As Mosab indicated, I'm currently in Boston, both at Boston Children's Hospital and Harvard Medical School, but as you pointed out, I was born in South Africa, in Johannesburg, in the early 1950s, went to University of the Witwatersrand to medical school there. This was the height of the apartheid regime. When I was a senior at medical school was when the 1976 Soweto riots were. And when I was finished my medical school, I was supposed to go in the army for 3 years, but I left the country without going into the army as a draft dodger and went to London. And frankly, I thought I'd never come back to South Africa, but 13 years later, Mandela was released and I could return to visit my family there. So what I'd like to share with you is work that we've been doing for the last 15 years or so, work that has an unexpected translational opportunity, because most of my work has been devoted to the study of pain. But what I'd like to share with you today is how unexpectedly sometimes you can do research and it may have implications for fields beyond that you started looking at. So basically, I've been working as part of a team on devising new therapeutic approaches to silence particular sensory neurons. The current standard treatment for silencing neurons is using local anesthetics like lidocaine, and these are non-selectives. They block activity in all excitable cells, both the nervous system and the cardiovascular system. And they are non-selective. And Bruce Bean and I, Bruce is a faculty at the neurobiology department at Harvard Medical School, set ourselves the task of seeing whether we could devise a strategy to selectively target nociceptors, which are those high threshold sensory neurons that initiate the sensation of pain because they detect noxious stimuli. And then at some point, which I'll discuss with you, we realized that this work may have implications for the treatment of cough, which is a surprise, but when we realized that the sensory innervation of the upper airways in many respects resembles the sensory innervation of the skin and other organs. And there are many nociceptors in the airways, and these trigger a cough response. So this was a strategy, and we developed this in collaboration with Bruce Levy, who is head of the Division of Pulmonary Critical Care at Brigham and Women's Hospital. And this work has led to the formation of a startup company called Nociceptor Therapeutics, which has licensed this technology from Harvard. And what I'd like to share with you is how certainly things have changed in academic neurobiology. When I first started, there was almost zero contact with either biotechs or pharmaceutical companies. But increasingly, we now collaborate, we share, we have ideas that industrial companies can then develop into new therapies. So this is a new model of doing science. So as I've indicated, cough can really be considered as itch of the airways or even pain of the airways. It's triggered by the activation of these highly specialized sensory neurons, the nociceptors, and it produces a response that is different from the ouch pain that we get if we have a pinprick or touch something that's too hot or too cold. But at the same time, it has many features. It's activated by noxious stimuli. It produces a very standard response instead of a withdrawal response. It's a cough response. And in the presence of inflammation, the trigger becomes reduced, becomes what we call sensitized. One of the major problems with cough is it's extremely common. Actually, between pain and cough, these are the two most common reasons why people go to see a physician. And at the moment, we have very few treatments that are available. And those that are available have quite substantial side effects. So in consequence, just from a safety point of view, if you go to your pharmacy and get an over-the-counter treatment for cough, the chances are that it'll have the same effect as if you got a placebo. That there's minimal effect of the over-the-counter drugs. There are some ways of interfering with cough, and I'll show you in a moment, but they do have problems. So back to nociceptors. So nociceptors are that highly specialized set of primary sensory neurons that are activated only by intense or potentially damaging stimuli. And this is just a model to outline the peripheral terminal of these nociceptors. And what we now know is that noxious stimulus act on particular sets of ion channels and receptors, which convert the stimulus, whether it be mechanical, thermal, or chemical, into electrical activity. And one of the major ion channels that does this is TRPV1, which is a large pore ion channel activated by chemical irritants such as capsaicin, which is the pungent ingredient in chilies, and also by noxious heat. And in fact, the reason why we say a chili sauce is hot is literally because we have it acts on the same receptor that heat does. So TRPV1 is expressed by nociceptors. If you eat a chili, the burning sensation in your mouth is due to the activation of TRPV1. If you inhale a chili, you'll cough for sure because the nociceptors in the airways also express TRPV1. And then our skin has it. If you happen to touch capsaicin, you'll get an intense burning sensation from this. So the nociceptor converts peripheral stimuli into electrical activity. When TRPV1 is activated, there's an ion flux, particularly calcium, into the cell that depolarizes the cell, and that triggers voltage-gated sodium channels to initiate the action potential, which carries information from the periphery to the central nervous system. So I don't know if you recognize this individual. His name is David Julius, and he won the Nobel Prize for Physiology and Medicine this year. And he won it by virtue of discovering TRPV1 being the capsaicin receptor and the heat receptor. So how can we inhibit nociceptors? Well, there are two general strategies at present. One is using local anesthetics, which act on sodium channels, and they inhibit the excitability in these sensory neurons by virtue of blocking the capacity of these neurons to generate action potentials and to carry information from the periphery to the spinal cord or to the brain. However, the currently available local anesthetics are non-selective, as I've indicated, which means that if you go to the dentist and you get an injection of lidocaine, yes, you will have analgesia, but you'll also lose touch and you'll also lose motor function. And this is the consequence of this non-selectivity. So it produces general numbness and paralysis. And in addition, lidocaine acts on the heart. And the heart is an excitable organ. And if you have too high lidocaine, you can have major side effects due to arrhythmias in the heart. An alternative strategy to block nociceptors is to use opiates, morphine-like compounds. And the way they do this is they express the mu opiate receptor. And when this receptor is activated by opiate ligands, it blocks the synaptic transmission. It acts presynaptically on these nociceptors, preventing them activating neurons in the spinal cord and the brainstem. It has a relatively long duration, much longer than local anesthetics, which are short-acting and only last for an hour. However, it has many side effects that I'm sure you're familiar with. Some of them are not that serious, they are pleasant, such as itch. Others, as a consequence of the mu opiate receptors that are expressed in the gastrointestinal tract, produce symptoms like constipation, which is a major problem for people who are chronically taking opioids. But the major problem is respiratory depression, which is the reason why high doses of opiates are actually lethal. And again, another major problem of opiates, of course, is their abuse liability, leading to addiction and diversion. And in consequence, there is this horrific opiate overdose and abuse problem in many countries. So we need alternative strategies that don't have the problems of local anesthetics, they're non-selectively and short action, and a way of eliminating, if possible, the use of opiates. So how to do this? Well, pain, itch, and cough is triggered by electrical signals in nociceptors, so they are activated, they then transfer this information to the periphery. And the challenge then is there a way that we can potentially stop these electrical signals, the action potential generation and conduction? Can we stop them and in this way stop pain? So this is a dish filled with primary mouse DRG neurons, also ganglion neurons. These are cell bodies of sensory neurons, and the majority of them are nociceptors. And this is a glass electrode that enables you to make recordings, wholesale patch recordings. This is what the firing of potentials on depolarization looks like. So this is our challenge. Can we devise a strategy whereby we can selectively block activity in nociceptors, but leave the activity in other excitable cells intact? So let's look at how local anesthetics act. So this chemical over here is lidocaine, which is one of the most commonly used local anesthetic. And when you give the drug, it exists in two forms. It exists in a charged form and a free base, an uncharged form. And it keeps on reverting, and this is affected by pH, but some of it is in the charged form and some of it is in the uncharged form. It is the uncharged form that then diffuses through the membrane from the extracellular space into the cytoplasm. And once it's in the cytoplasm, once again, you get the constant to and flow between the free base and the charge form. And it's the charge form that then blocks the cytoplasmic side of voltage-gated sodium channels to inhibit their ion flux through these channels. So this is the way in which local anesthetics work. When you give them extracellularly, they have to get into the cell intracellularly. To do that, they need to be lipid soluble. And once they're in the cell, they can then block the sodium channel and produce their blockade of excitability. And the challenge that Bruce Bean and I set ourselves was saying, well, instead of having an individual target, a class of targets, voltage-gated sodium channels, on which a class of compounds such as local anesthetics act, is there any way that we could devise a strategy whereby we could have a cellular target? In other words, can we devise a way by which we can selectively reduce the excitability in nociceptors without affecting any other excitable cells? And the way we looked at that was we said, well, what makes nociceptors special? They have these transducer channels such as TRPV1 on their periphery. That's important. Does that give us a clue? And they also have some unique species of sodium channels which are not present in other cells. So how to selectively silence nociceptors then? Well, there are two ways. One is you could block the transducer receptors such as TRPV1, and the other one is you could block the sodium channels in these cells. And the idea that we came up to do this was to exploit large pore channels to deliver drugs into activated nociceptors. If you look here on the peripheral terminals of nociceptors, TRPV1, TRPV2, TRPV3, TRPA1, all of these are large pore channels, including P2X2. So there is something unique about the channels that convert thermal, chemical, or mechanical stimuli into electrical activity, that there are large pore channels. And having realized that, and this is a cryo-EM of TRPV1, we set out to explore whether we could inhibit nociceptors by using large pore channels as a means of delivery of drugs into nociceptors only. And this is a paper that we published some years back in Nature. This is Bruce Bean, my major collaborator. This is Alex Binstock, who's a postdoc in the lab. And basically our strategy was to say, instead of having lidocaine, which is in a free base form and a charge form, if we converted lidocaine to a permanently charged compound, it would not be able to diffuse through the membrane because it's charged, therefore it would be hydrophilic, not lipophilic. But it may be small enough that when TRPV1 and other large pore ion channels are activated, it could allow the drug into the cell, but not into cells that don't express TRPV1. And in this way, it could selectively silence nociceptors only in those cells that have activated large pore channels. And this was our silencing strategy that we set up for ourselves. And it's ironic, again, this is David Julius, this is Artem Pataputian, who also won the Nobel Prize. David discovered TRPV1, and then both Artem and David discovered TRPA1. And basically what Bruce Bean and I are using is this discovery of large pore channels as a drug delivery device, rather than as a target for inhibiting the activity of these transducer proteins. So we're using the fact that nociceptors, by virtue of their function, detect noxious stimuli. They do it through large pore channels, express these large pore channels, and these large pore channels potentially can allow a permanently charged drug to enter into the cell where it could produce this silencing. And that's exactly the strategy that we developed. A conventional anesthetic such as lidocaine diffuses through the membrane and can then block it. our strategy was to convert the lidocaine into a compound which is called QX314, which is permanently charged, and then to see whether it could travel through large pore channels into the cell, and again could silence the cells, but it won't get into cardiovascular cells, it won't get into motor neurons, it won't get into those sensory neurons that mediate light touch or vibration, because none of them express large pore channels. So lidocaine, which is non-selective, inhibits pain, itch, cough, but is very short acting because it gets into the cell by diffusing through the membrane, but it also diffuses out of the cells. It has this bidirectional diffusion. It's non-selective, as I've indicated, it produces general numbness and paralysis, and it has cardiovascular side effects. And our bid was to see that by making permanently charged sodium channels that would only block sodium channels in activated nociceptors, because these would be the only cells that could get into by virtue of traveling through these large pore ion channels. This would then produce a drug effect that would be long-lasting, because once the permanently charged compound was in the cell, it would not be able to diffuse out. It would be selective. It would only act on those cells that have large pore channels. These happen to be nociceptors, and one could do this with minimal systemic exposure, because a feature of charged compounds is they don't spread throughout the body. So if you give them topically to a local area, they'll remain in that area. So we set out this. These are some of the papers that we've published on this, and basically our hypothesis turned out to be correct. That if you take small sodium channel blockers, permanently charge them, if they have no effect on motor neurons, cardiovascular neurons, and low threshold mechanoreceptors. They do not cross the blood-brain barrier, they do not act on neurons in the brain. So they have minimal activity, but they do enter nociceptors when their large pore channels are activated, and this then produces a long-lasting block of those sensory neurons that produce pain, itch, and cough. And what I'd like to share with you is our most recent data on the strategy, which is on cough. This is a paper in British Journal of Pharmacology that was just published earlier this year. And this is an attempt to see whether this strategy of using charmed sodium channel blockers can inhibit both inflammatory pain and cough. So here is the chemical structure of lidocaine. The first charged molecule that we used to test this hypothesis was something called QX314, which was well known in the literature as a charged sodium channel blocker that had no activity when given extracellularly. But if you put in a patch electrode, it blocks the cell. So it was being used as a way of selectively blocking sodium currents in cells when you're doing the patch recording. But what we discovered is that you can get QX314 into cells through trip channels. And then for this particular paper, we did a drug screen to see if we could make charged sodium channel blockers that were more potent and had better drug-like qualities. And one of them is a compound called BW031, which I'll show you in a moment. So one of the first things we want to do is to confirm that if we looked at two sodium channels, one NaV1.7, which is expressed by nociceptors, and one NaV1.5, which is expressed by cardiac cells, cardiomyocytes. We wanted to see that our charged sodium channel blockers had no effect. And so we gave them extracellularly two cells that were heterologously expressing these channels. And basically, you can see that there is absolutely no inhibition of human NaV1.5, except to go into the very high millimolar range. So there is no, in the micromolar range, there's absolutely no effect of extracellular charged sodium channel blockers on this ion channel. And that's true also of sensory neurons. You only get block at very, very, very high doses, indeed, high millimolar doses. However, if you look at DRG neurons, So these are mouse neurons. We are looking whether we can selectively inhibit sodium current in those cells that respond to capsaicin, and the reason they respond to capsaicin is because they express TRPV1. So if we look at the size of the sodium current in a number of these cells, this is the size. We then give our charged sodium channel blocker BW031. There's no effect whatsoever. Extracellularly, it does not change the sodium current. If we then give capsaicin, which activates a subset of the neurons, there is a slight depolarization, but not a significant reduction in the sodium current. But if we give the capsaicin to open TRPV1 and we give BW031, even the BW031 by itself does nothing, but when given in the presence of capsaicin, which activates TRPV1, you can see we now get a very significant reduction in the sodium current in TRPV1 expressing neurons. If we look in those neurons that do not respond to capsaicin because they do not express TRPV1, the combination of capsaicin and BW031 has no effect because the BW031 cannot enter the cells. So this shows that activation of large port channels is a drug delivery system that allows charged sodium channel blockers to get into the activated cells and inhibit their currents. And this just shows you how, if we record the currents using whole cell patch recordings, you can see this is the effects of on the sodium current when given extracellularly and intracellularly, and you get a massive block with only when you give it internally, but not externally. And if you've got no drug, there's no inhibition of this sodium current. So it only works extracellularly, and BW031 is more potent than QX314. So we have identified a charged sodium channel blocker that has no activity extracellularly, only intracellularly, and is more potent than the original tool compound BW031. And we could then test whether it produces any pain. And to do this, we had a number of pain models in the paw of mice and rats. This happens to be one where we produce inflammation in the hind paw using complete Freund's adjuvant. This is pre the inflammation. This is after the inflammation. You get a reduction in the threshold required to initiate a paw withdrawal. And if we give our BW031, we prevent this reduction. So we block the inflammatory pain hypersensitivity, and a single injection of BW031 has significant effects for at least 7 hours. And the efficacy in a different model is greater than QX314, which has an effect, but it's relatively short-lasting, whereas our BW31 has significant effects up to 7 hours. So that's on the pain side of things. What about cough? How do you measure cough? Well, it turns out that mice and rats do not cough, which is a bit complicated, but guinea pigs do. And this enables us to measure cough in these animals. We do this by inhalation of citric acid. There you go. So you can measure quite readily the coughs that are produced by citric acid challenge. And then we wanted to see if inhalation of a charged sodium channel blocker could block that. So what we did was to do this at a general anesthetic using isoflurane. And it turns out, a big surprise, but a group in Germany a few years back showed that many general anesthetics, particularly isoflurane, activate TRPA1 and TRPV1, so these large pore channels. So we got activation of TRPV1 and TRPA1. We then give citric acid as a challenge, which then causes cough in the guinea pigs. And we can see whether QX314, our tool compound, reduces the cough. And you can see here that 30 micromolar inhaled almost completely eliminates the cough, and that at lower doses you get at 3 micromolar, you get about a 50% reduction in the cough. So this shows you that if you have activated large pore channels in the nociceptors in the airways, and you inhale charged sodium channel blockers, this can get into these nociceptors and then block the effect of the citric acid challenge, which normally provokes a cough response. We then did another model, which is hopefully more closer to the human cough conditions, which is to sensitize the guinea pigs to ovalbumin by giving repeated systemic exposure, just a subcutaneous injection of albumin on day 0, and then you have an inhalation of albumin. Basically, this sensitization causes T cells to recognize this foreign antigen, and you then get an allergic response when you have the challenge. And the inhaled allergen causes an allergic cough response. So instead of being an irritant like citric acid, you can provoke an allergic airway inflammation. And then we wanted to see whether our charged sodium channel blocker, our novel one, BW031, can then block the cough that occurs in response to the citric acid challenge. And here we can see the cough count triggered by citric acid when given different doses of our novel charged compound. And basically, we see a significant reduction in all the doses. And it turns out to be more potent than QX314. In addition, it also reduces the inflammation. So not only do we block the cough, but we also reduce the inflammation produced by the challenge, the allergen challenge. And that reflects the fact that nociceptors not only produce sensation, but they actually reduce neuropeptides, which amplifies inflammation. The inhaled BW031, we also measured the level in plasma after this inhalation, because we were worried, was it systemically distributed? Would it have effects on the potential side effects? But you can see the levels in the plasma were extremely low. The IC50 of this is about 10 times higher. So this is 20 times higher. So this is way below the effective dose. And there was no effect of the BW031 on the natural beating of cardiomyocytes at all. So it does look like inhalation of charged sodium channel blockers are effective in reducing cough and do not seem to have a risk of adverse effects. So I mentioned earlier that a startup company took this technology, and they are developing a path to the treatment of patients with cough. And this was an announcement that was made in August this year, whereby Nociceptor announced that their dosing is underway in patients with chronic cough, studying the effect of a charged sodium channel blocker to see whether this works in patients. And hopefully we'll know about the middle of next year whether this clinical trial was successful or not. So our goal then was to see whether we could introduce a new and effective treatment in cough. And we will now be able to see whether this indeed is true, because we have a clinical study running at present, both in the UK and in Germany, that is testing this hypothesis. And the treatment is not restricted only to cough. We're using it by virtue of the fact that you can only give it locally So an inhaled aerosol or inhaled dry powder is a very convenient way to deliver the compound to the sensory neurons in the airways. And this then can be used for chronic cough, post-infectious cough, asthma, chronic obstructive pulmonary disease, etc. So this will be investigated. However, it can be used for other indications as well. But it could be given by ointment or creams or eye drops for atopic dermatitis, which is allergic inflammation of the skin, for itch, pruritus, allergic conjunctivitis, for those of you who get spring hay fever, this is allergic conjunctivitis, and there are other common diseases of the eye that are due to inflammation. It may have use for dental pain, treating dental pain, GI tract pain, gynecological pain, etc. And in fact, it is possible, because it's not observed, that one could take a capsule orally, and this could affect oral mucositis or inflammatory bowel disease, etc. And this is something that we hope that this new discovery coming out of academic labs can contribute to the development of new therapeutic strategies. This is a paper that actually a former undergrad student of mine from Harvard did the work in my lab, and she's now a medical student at UCLA. And this paper just literally came out a week ago, showing that in addition to the effect on cough and the reduction in inflammation in cough, in models of atopic dermatitis, this allergen-induced allergic inflammation of the skin is reduced by silencing nociceptors. So I'd like to end by thanking those bodies that provided the money that enabled this to occur, particularly the NIH and the Department of Defense, which provided money, as well as the Charles Hood Foundation and then Boston Children's Hospital Technology Development Fund, the Blavatnik Biomedical Accelerator at Harvard Medical School, as well as the Boston Biomedical Innovation Center. This has been a long-standing project. I mentioned Bruce Bean and I developed the strategy. Bruce Levy has helped us adopt it, particularly for the application for cough. And then I've had a number of very skilled and able and highly motivated postdocs and research assistants in the lab who've helped us do this. And then finally, this is the team of Nociceptor, which I'm a founder of, but it's a completely separate company. I have no executive role in the company, but nevertheless, this is their motto: charging forward using charged sodium channel blockers. So I hope you found that useful, and I would be happy to take any questions.
Yeah, thank you very much, Clifford, for this wonderful talk. Let me see if we have got some questions, but while people gather their thoughts and come up with more questions, let me ask if there is a piece of advice that you may have picked along the way and you want to share with anyone listening, particularly our young audience or early career researchers.
Yeah, the advice is life is full of surprises. If you asked me when I was at medical school in Johannesburg, would I land up at Harvard Medical School, I would have said never in a million years. In fact, at that time, there was closer academic links with the United Kingdom. But you know, when I finished my PhD at WITS and was writing to try and get jobs to avoid going into the army, I wrote 100 letters to labs in London looking for a job, and I didn't get a single reply from one of them. And it was just by chance that an opportunity came up in the smallest component of the University of London Medical School at the Middlesex Hospital Medical School, where an open position came available. But persistence is the most important thing. Don't give up. Have a goal. Keep going. Realize that sometimes you'll be pushed into areas or do things that are different from what you may have planned, but keep on going And that is one of the most important elements of success, is not giving up.
Yeah, great. Someone is asking, in case of patient with fibromyalgia syndrome, can this treatment be effective as well?
Not really, because a feature of this particular treatment is it needs to be given locally. You can't take it as a pill systemically. So conditions that are like fibromyalgia, which are not localized, but often are chronic widespread pains, wouldn't be something, unless a patient had a very distinct localized area, then potentially could inject the drug into a single muscle.
Another question, I don't know if it is relevant or not, but he is basically asking if this could be involved or implicated in sleep medicine by any way or another.
Sorry, it could be involved in sleep medicine. Oh, yeah. Right. Well, the answer is it could be. And the reason for that is that one of my postdocs, Al-Neelain, his wife was a postdoc in the sleep medicine lab, Tom Scannell's lab, here in the Longwood area. And they started looking at the interaction between pain and sleep. And they found, for example, if you deprive a mouse of sleep by not completely, not 100%, but you interrupt it so it has much less sleep, then its pain sensitivity goes up very dramatically. And equally, they've also found that when you have spontaneous pain, particularly after nerve damage, it produces brief awakenings. It actually, if the animal's asleep, then suddenly there's a burst of activity in the injured nerve, and this causes a brief awakening. So there is an interaction between sleep and pain. And one would anticipate that from a therapeutic strategy, it's best to try and treat both of them. Although if you reduce the pain, the sleep may get better. Equally, you've got to be aware that many of the drugs that we use for treating pain, like gabapentin, also have a sedation effect as well. And some patients find that just very disturbing, that they can't wake up properly, and when they do wake up, they don't feel as alert as normal.
Yeah, great. Someone is saying, thank you very much. However, I can't find application for neurodegenerative disorders on the slide showing platform for multiple therapeutic candidate. I guess he is asking if also there is an implication for neurodegenerative disorders.
Yeah. So again, this is a target for nociceptors. So in terms of neurodegenerative diseases, the only ones that would affect nociceptors are certain neuropathies, particularly small fiber neuropathies, of which diabetic neuropathy is the commonest, but there's also idiopathic small fiber neuropathy. So these are diseases where you get axon degeneration in nociceptors. And in some of the patients, they go on to develop neuropathic pain. So there are a subset of patients with diabetic neuropathy who develop quite severe pain with a particularly strong spontaneous element. And the question then is, could you target their nociceptors in this way? And again, the problem there is that this is a treatment that has to be topical. It has to be applied to a surface like the skin, or inhaled or injected, which just makes it difficult for someone who has a disease like diabetic neuropathy, where the chances are very high that many of their nerves will be affected, and you'd have to give injections to multiple nerves. So this is a strategy that has particular uses, but unfortunately it also has limitations, which means that we need to continue to develop other forms of therapy that could be useful for fibromyalgia and diabetic neuropathy.
Okay, another question. Thank you so much for this nice presentation. It was surprising to see how cough can be induced in a guinea pig. What other methods can be used to induce cough? I mean, I don't know if you got his question.
Yeah. So as I said, it's extraordinary actually, given that pain and itch and cough all have a protective function. They tell us about danger in the environment and they initiate a response that reduces that danger. In the case of pain, obviously, if you touch something hot or too cold, or expose yourself to a pinprick, you withdraw your body from the stimulus. In the case of cough, what you're doing is trying to get rid of potential irritants or pathogens in the airways by coughing them out. What is surprising, as I said, that why do mice and rats not cough, even though they may be exposed to dangerous pathogens? And that is a fascinating question that requires a sense of, what are the drivers in those particular mice that didn't lead to the presence of a robust cough system. But in guinea pigs and certainly in humans, there is cough. But the trouble is that the clinical conditions, particularly the chronic conditions, which was one of the major unmet clinical needs, where patients just cough and cough and cough, and they have no longer active inflammation, they're not post-COVID immediately, but they cough for years and years, and they often have fibrosis of their airways and lungs. And we don't know the cause of that, and we have at present no form of treatment. And the trouble is we've got no way to really model it, because even though we can get cough in guinea pigs, we don't have this chronic interstitial fibrotic cough that is a feature of patients. So in the end, we're going to have to tease out whether this treatment is going to work in different subsets of patients. And it's actually quicker to try and get something safe. And so far, the phase 1 study that Nociceptor has conducted was completely safe. And so we can hopefully, if there are enough supporters of this strategy, that we can test it in multiple groups of patients.
Okay, another question. You mentioned that pain is connected to sleep medicine. Could this be applied to seizure control?
Not really, not seizure control. The effects that we see with neuropathic pain models are just a brief awakening. If you look at the EEG, you see the typical REM sleep, and then suddenly there'll be a brief awakening that lasts a few seconds, and then the animal goes back to sleep. So it's not a seizure. It's just it's a bit like an attention. It's just something that triggers a sufficient change in the cortical function that someone would say, "Oh, I'm awake," and then they fall asleep again. And they awake because they've got this pain trigger, if you like, which if you're awake, you'd say, "Oh, I've got my spontaneous pain is there." If you're asleep, you wake up.
Okay, we have got 2 questions. Do you think this could be applied as preventive treatment in surgeries and therefore prevents the development of a potential neuropathic pain?
Yeah, that's a great question. So when I started my career, actually the reason I got into pain was that the first time I went into a post-surgical ward, the resident, the registrar, was there, and I saw all the patients. There must have been 10 patients who'd had surgery that day, and they were all lying there moaning and groaning and crying because they were all in severe pain. And I said to the resident, why are they in pain? He said, "Well, they've had surgery. What do you expect? If you have surgery, you have pain. And if it's a way of us keeping on tabs on how the patient's doing." And frankly, I said, there's something wrong with this. You shouldn't allow your patients to endure that. And so based on that, I did some work when I was at University College London, comparing the effects of treating pain before it occurs to anticipate it, and treating it when it was established using an acute surgical type model. And we found that if you gave the treatment before, you got much greater analgesia than if you waited for the pain to be there. And this led to the concept of preemptive analgesia, giving your treatment early. And this was an enormous battle. We actually did, I did my first clinical trial that was published in Lancet, showing that if you gave morphine early, you got a much greater effect than if you gave it later. And it took a long while to persuade the clinicians, but now people do it routinely. If you go for surgery, you'll get your analgesic right at the beginning. So when you wake up, you'll have much better pain relief. So the answer is yes. Whether we can protect neuropathic pain is another matter altogether. And unfortunately, I think that's going to require something different to prevent the consequences of the damage to the nerve.
Okay, another question. Have you looked whether this specific inhibition reduces the reactivity of non-neuronal cells in the DRG or sensory neurons?
Yeah, we have looked, and certainly in the DRG, this treatment only firstly, the low threshold sensory neurons are completely normal; they are not affected. And then the satellite cells, which are the glial cells that surround the sensory neurons, are not affected, nor the Schwann cells. So this treatment is selective to a subset of sensory neurons only.
Great. I guess we already run out of time. So would you like to provide kind of closing remarks for our audience before we close today?
Well, just again to say, since my career started in Africa and I was forced to leave Africa, and as a consequence of that, do not have strong connections with Africa because I worked both in London and now in Boston. But it's been a real pleasure to come back, and I hope this work inspires you and helps you move forward and make an impact in this field.
Yeah, thank you very much. And as I mentioned before the talk, we would be more than happy to invite you for our next conference in South Africa. So with that, let me thank you again for this wonderful talk, and also thank our audience for the engagement, for making this webinar interactive. And see you in our next webinar, and bye for now. Thank you very much.
Goodbye.
Bye.